Hello and welcome to Rural Doctors. I'm Gina Williams. In this program we take a look at the services supporting patients and practitioners working in Indigenous health all across the state. But before we begin, here's a quick word from Rural Health West's CEO, Belinda Bailey.
Hi everyone, this is just to let you know that nominations are now open for the Rural Health West Doctor Service Awards. You probably know that every year Rural Health West recognises hard-working rural doctors for the amazing work that you do out there. Nominations now open for a range of categories that we like to recognise every year, and we'd love you to jump on the Rural Health West website, download a nomination form, fill it in and email, fax or post it back to Claire Underdown, the Marketing and Communications Coordinator here at Rural Health West. The awards ceremony is attached to the annual conference that Rural Health West runs every year around March, and next year it'll be the 17th and 18th of March in Perth. So we'd love you to nominate a doctor and maybe come down and be part of the event, which is an amazing day where colleagues get together and support each other and recognise each other peer to peer, and we'd love to see you there.
Thanks, Belinda. We're getting better at providing health services for Indigenous people in their own communities, but inevitably some patients still need to travel to Perth to be admitted into a tertiary hospital. In our first segment, we look at the support provided to Indigenous patients travelling to Perth by the Aboriginal Meet and Assist team at Country Health Connections.
Many years ago, Aboriginal people were coming to Perth for medical care, and they were really getting lost in the system and they needed to be coordinated. And we needed a proper discharge program. So approximately 30 years ago, a section was called Communication and Escort was started to coordinate the discharge of patients back to the remote areas. A lot of them were elderly people and were finding it hard to cope with coming to Perth. You can imagine that they suffered culture shock. A lot of the staff that are working on the wards come from overseas and they're not used to dealing with Aboriginal people. And of course the Aboriginal person, when they get to Perth and land in a huge acute hospital, they suffer great culture shock and they're really frightened. And so some of them really get under the blankets and they stay there.
Okay, thank you for that. Oh, good lady. This lady's just taking a little bit of footage of us.
It's changing a little bit because we've got Aboriginal liaison officers coming into the hospitals now, and we're starting to pull back a little bit. But we are on call for anybody to go into the hospitals and to do a visit and to see the clients and then to do any follow-up care that's required.
Hello, how are you going? I've got Yolanda here, booking her into Derbal today. Okay. Yep. Okay, she's just got a form for you to fill out, just take some details.
Yep.
And they'll be able to book you into a room, settle you in. They'll explain all the rules and meal times and that here for you. And we pull in here every morning to take you to your appointments, and we'll provide that transportation for you here. So if you've got any appointments, just let the managers know what days and times so then they can communicate with us and let us know to pick you up.
The people that we predominantly talk to are the people from the Kimberley, Pilbara, Eastern Goldfields, which takes us right out to Alice Springs, and then we also deal with some people from the southwest as well.
We've got cancer patients, we've got renal patients, those that may come down for surgery, maybe on their knee, or those that have broken an arm or leg, eye for their eyes, and then the cancer one for their head and neck one, and then there's other cancer problems that they have. Also those coming home with babies, the mums, and yeah, all kinds of health issues which it's up that way, yeah.
Now if they require help at the airport, this is where we come into it with our meet and greet team.
How you going? Come to meet again. Okay, you got luggage over here?
Yeah,
All right then. We'll pop over and get your luggage.
We also arrange accommodation in Perth, and of course this is so important because people must be made safe when they get to Perth. And with Aboriginal people, mainly from the rural remote areas, they really do need an appropriate place to stay. And this is where they get 3 meals a day, 7 days a week, and they're not wandering around the streets, and they are looked after properly.
There are 2 Aboriginal hostels. Alba Grove, that's the short-term ones that come down, maybe their appointments today, and then it's over, and then we put them on the plane and send them back. And then there's Derbal Yerrigan, which is a long-term one that may be down for 4 weeks or up to 2 months.
We take them to the hostel to start with and book them in. And then if the following day they require to go to King Edward, PMH, Royal Perth, Shenton Park, Fremantle Hospital, we then organise either the meet and greet team again to take them, or we organise taxi vouchers to and from. Part of our role is to encourage and teach people to become independent and to look after their own needs and get themselves to and from their appointments. And we do this through the working of the health workers and explain to them why they are in the situation they are in. And we feel driving the people to appointments is a good place to start health education.
Now, I've got a personal experience with my son, who's no longer with me because he had bowel cancer at the age of 26. Now, that was 10 years ago. And there's young ones coming down, and I kind of use that, and it sort of makes them feel a bit at ease. I find a lot of them sort of relax a little and realise that they're not the only ones, why me type of thing. And with my daughter, they seem to relate to her being a younger person, and she'll go all the way, she'll pick them up like I do, then she'll take them she'll take them right into the hospital, take them right to the ward where they need to, even if they're just an escort for the patient that is in hospital, she'll take them right there and ICU and make sure they're safely there, which I do too. But, you know, they appreciate, because some of them don't know a big hospital. No, it's new to them, that's the first time they've come down. So we help as much as we can, you know, and look after them safely and that.
I'll have to check it out, find out. All right then, we'll book you in. Daylight. I can't see her name, but
She knows she's coming home.
I hope so.
Earlier today?
Yeah, we would have booked her in probably a couple of days ago.
Oh, well, yeah.
That's what I'm thinking.
Shouldn't be too long.
All right. You is booked in here. Well, you wasn't booked in here, but they're going to take you. But they're going to take you. They room.
She'll share a room.
There you go. All right. Linda's just got some paperwork for you to fill out.
Yeah.
Yep.
So she is escort for this one?
No.
No? She's on her own.
She's on her own.
Right.
They family. Yeah.
Yep. So, medical.
So all your paperwork, you want to give them to Linda so that she can, all your papers, appointments?
I'll ring them up for appointment.
So what's your appointment?
And you give them.
You got the papers, what the doctors give
They
you?
never give me anything like they never tell me.
What papers they gave you from up back home?
On the touch phone.
You want to bring that here? So we can just have a look through it?
Tell me what time my appointment and everything.
So that they told you you have to ring, oh no, hang on. Tomorrow. Yes, see you. Tomorrow, 3 o'clock, okay? Alright, so that's, and then you get your sign.
Get on the doctor.
Yeah, doctor sign. And you got your 2 taxi vouchers, okay? Your appointment's at 3 o'clock, so I'm guessing I can't take you at that time because we're pretty much in the office by then.
Yeah.
So Linda will give you one to get there, and then she'll probably give you one to get back to the hostel there. Yeah, pretty much, because you might be there a bit later. Who knows how long you'll be waiting for. Alright then. Alright, I'll pass that on to Linda so she can write it all on the board so she knows what's going on with you, okay? And she'll tell you what room to go to. But alright, then I'll leave you where Linda will look after you. Okay.
We work with probably 2,500 people per year. They all come down through the PAT system, and some of them do come down through flying doctor system, hospital to hospital, but then we discharge them. They do attend all their appointments, and then we get them home safely. And probably 99.9% of them get home without anything happening. So we are very proud of that.
Yep, alright. Alright then, Yolanda, you'll be fine. The ladies will look after you here and I'll probably see you in the morning. Okay.
Thanks to everyone at Country Health Connections for their time. Next up, we chat with Dr. Alex Balzarelli about UWA's Centre for Aboriginal Medical and Dental Health and improving the recruitment and retention of Aboriginal students in medicine.
Hi and welcome to the program. Thanks for joining us today.
Morning.
Lovely to be here. Could you tell me a little bit about how CAMDA developed and how the students particularly are supported compared with, say, 10 or 20 years ago?
CAMDA's been around for approximately 20 years now and evolved essentially to create opportunities for Aboriginal students to get entry into medicine, dentistry and the health sciences. So what CAMDA looks at doing is engaging students much earlier than what you would usually engage students for tertiary study. We work collaboratively with the School of Indigenous Studies and do, say, Year 8 Discovery Days, Year 9 Exploration and Science camps. We also do then, in the senior years, a health science camp where students come from all over the state, predominantly Aboriginal students come from all over the state, to learn about health careers and subject selections and an opportunity to engage in the different health careers that exist. So as an example, there's an opportunity to do some plastering and some suturing, to talk to podiatrists and some of the nursing students about what it is that health careers and what health careers entail. There are a range of entry pathways in which students can enter into medicine at the University of Western Australia, and there's also a wide range of support mechanisms that are in place to enable students to be able to engage and participate at tertiary studies and at university and to help them throughout their degree so that we ensure that students graduate at the other end of their chosen study period.
And because it's been around for 20 years, I mean, you guys might not have been around for 20 years, but you would have seen a lot of people come right through that process at the other end and have gone into specific fields of study and work and, I guess, success stories.
Dr. Helen Milroy was the first that graduated at the School of Medicine, the first Aboriginal student that graduated from university. And since then we've probably had 21 others medical students graduate, which doesn't sound like a lot of students, but in reality, when you think about medicine's 6-year course, it's quite a rigorous course, the length of time which people need to study, the support that happens along that way, and all the different family and other obligations that happen for Aboriginal students while engaging in medicine. That's quite a high number of students graduate. We don't just graduate students in medicine, we've also graduated, last year we graduated our first Aboriginal dental student. Oh, great. And this year we're about to graduate our second dental student. That being said, we also support students that don't graduate in medicine to engage in another career path, particularly within health. And so a large majority of our students, probably about 90%, even if they don't graduate in medicine, still graduate with a degree in health and still go on to work within the healthcare sector and often with Aboriginal communities.
Have any of those 22 gone into different areas, totally unrelated to Indigenous health?
Yes, we've had, I know of one we've had our first paediatrician. So
fantastic.
He's actually working up in the Northern Territory now. We've just graduated our second, I think, psychiatrist. So we're really proud of that. And currently we have one person in the cardiology program.
Sure.
Like you said, Alex, while the majority of them do go back to communities or in Indigenous health, we do have some specialists.
Mentorship is one of the other things that all of us are involved in, and I think it's a privilege really to be able to, like you guys, you reach to all the medical students because you teach in every year, is it?
For medicine specifically, we teach across the 6 years of medicine. So what we try to do is build on our teaching throughout the 6 years, and it's integrated in key points where students are doing their learning, and within that we also have Aboriginal electives and selectives. So students who would like more Aboriginal health and gain a greater understanding around how to work in Aboriginal communities and Aboriginal contexts can engage in specific electives and selectives throughout their degree. And then those students that engage in that end up with an additional couple of letters on the end of their MBS to say that they've specialised in Aboriginal health. So there's a lot of opportunities for students within medicine. Students outside of medicine that are still in health, so in the dental school and podiatry and nursing and health sciences, social work, psychology, we also provide a range of teaching throughout their programs as well at various stages throughout the year. So there's a good chance that if you're studying health at UWA, then you'll come into contact with the Centre of Aboriginal Medicine.
Which is wonderful.
During those first 3 years where they're mostly in the classroom, we do all that preparedness then to get them to the clinical aspect. So in 4th year, we actually help them in a clinical setting. So, you know, most of students may not have had any contact at all with Indigenous people, and so we go in and then we do that preparedness to practice with them. So we're giving them like handy tips and hints to actually approach a patient, which we've had some feedback from some of the students who said, oh, that really worked, you know, something as simple as asking the patient, oh, where are you from? Where are your mob from? Or where are your people from? And they've used this approach and it's actually paid off well. So the patients, you know, it's already opened up that line of communication. And probably the one that I enjoy the most is when they actually get to go rural, so in 6th year. And it's just fantastic that they get to see us for the very last time, and we show a film that of some medical students who are going to be in the same situation they are in, so going out to a community. And the majority of students from feedback that we've had was that was fantastic, and you know, have really felt a bit more prepared. So yeah, we do think that we are making a difference in actually preparing people.
And as practitioners, what Chris and I spend a lot of time talking about is it's about inclusion, it's about partnerships, it's about collaboration. And what you're saying, and those students that really get it, is those students that figure out that working in partnership with Aboriginal people and starting to work alongside and go on that journey with communities is what's going to start to produce some of the outcomes, as opposed to imposing and thinking that people can prescribe and do what's best. And so it's really refreshing to hear that there are students that get it, and there are practitioners that are graduating that understand what we've been talking about for the last X amount of years for their degree, because that's essentially what we need practitioners to be graduating with, is not to be experts in Aboriginal health, but certainly to know how to work more effectively and to provide better health outcomes for Aboriginal patients when they do see the Aboriginal patients. Because the likelihood is that I don't think there's going to be a doctor that's going to be able to avoid seeing Aboriginal patients. So they just need to be able to do it well, not be experts in the field. So.
Obviously people fall into different categories and they have different desires for what they want to do in their medical careers, but I really do think that everybody should have a knowledge of Aboriginal health and spend some time in Aboriginal health. If you're going to be a neurosurgeon, it's definitely going to benefit you to know about the Aboriginal communities and where people are coming from. And you may or may not know which direction you want to go, and those are the other people that can benefit from broadening their horizons and trying Aboriginal health, like me, I found that it was just fantastic. It's the most challenging and the most rewarding part of my career, and I feel privileged to be a part of it. And also I say to people, you don't actually have to make choices for your whole life. You might just want to go up north and do 2 weeks in an AMS and try it out. In 5 years' time, you might say, I want to go do a month's locum at Fitzroy Crossing. You can do that. You can do as little or as much as you like, but it's just about having a go and seeing what Australia and Australians are like.
Similarly, I don't expect people to be experts in Aboriginal health, but I do expect to see changes occur. The reality is if we don't get changes occurring in Aboriginal health, then the issues that we're grappling with now and that I'm having to deal with as a practitioner, my daughter's going to have to start to deal with when she gets to be my age. And I don't think that's what our people need, and I don't think that's what the wider Australian society wants to see. What I think will occur is if people engage in Aboriginal health and work collaboratively with Aboriginal people and start to think about all the things that need to change within Aboriginal health, then we'll get a very different outcome. As I said before, it's not about being an expert in Aboriginal health, it's about doing Aboriginal health well. It's about implementing and practicing medicine as you know how to practice medicine, and that's all Aboriginal people are asking for. So is good medical practice and good health outcomes.
After all that discussion, thank you very much for joining us today.
Fantastic.
Thank you.
Thanks.
Despite the best efforts of so many health professionals, the remote nature of many Indigenous communities can be a huge barrier to community and practitioner collaboration in Aboriginal health. The Indigenous HealthInfoNet is a vast online resource available to everyone working in any area of Aboriginal health that provides resources and opportunities for collaboration. We spoke to Neil Thompson, Director of HealthInfoNet, about how it got started, why it's needed, and the types of resources it provides.
Oh, the HealthInfoNet really reflects the need for better information to inform people working in the area of Indigenous health. And I guess that need has been recognised for quite some time. Probably going back, in fact, to the 1950s, 1960s, when the National Health and Medical Research Council first recognised that really there was a big problem with Aboriginal health around the country, but people knew nothing about why. And so it really goes back a long, long time, the realisation of the need for such a thing as HealthInfoNet has emerged into. Now, what happened at that stage was the Institute of Aboriginal Studies in Canberra decided they needed someone to bring a lot of the information together nationally. And so actually in the early 80s is when I first moved there and took up the role that really ultimately led into the HealthInfoNet in 1997. Now, there's been a lot of emphasis in the last 20 or 30 years on evidence-based decision-making within the health sector. And again, broadly, that's the type of role that we emerged into. Broadly, we work in an area of research called translational research. It's a relatively new area and is really poorly developed, except perhaps in the clinical area. But again, what we do is we work in that area to try to bring the range of information that's relevant to look at, in fact, at Aboriginal health across the spectrum of Australia type of thing there. So we do a number of things we produce. One of the aspects is we will produce major reviews of different topics. So these are potentially along the lines of what would be needed if in fact we had really good evidence to make all the decisions based on different health conditions. For example, if you look at something like rheumatic heart disease, we actually ourselves haven't done much there, but fortunately an initiative back in 2005 of the Cardiac Society and the Heart Foundation led to the development of a document which has now become the blueprint of action for rheumatic heart disease in Australia. We do similar type of things with less intensity because again we haven't got the resources that they could bring to bear on the topic there, but at least it's something along that line there to allow people to actually look broadly at the topic there and get some sense about what the policy implications are. The most recent review we've come out with is about volatile substance use. And that's a big area, a big concern in remote parts of the country, particularly in Central Australia, where petrol sniffing really has been a major problem, causing not only deaths but also permanent brain damage amongst people actually who've used it heavily. We worked with an expert in the area, Sarah McLean, to develop this review of volatile substance use and the type of interventions which actually could be used. And so it's giving the ideas of the type of things which actually could actually be used to actually address that particular problem. Our website really caters for all people working in or studying Aboriginal health, and so therefore the type of information that people pick up will really depend on what area they're working in. Since we emerged out of the need really for a policy level, a lot of the stuff we do is of a higher level type of activity. It will actually help people general information about the topic, but it may not be quite so useful for people actually working at the coalface. You know, for example, it's only in recent years that we've actually moved some of the stuff we're doing to be a lot more tailored towards actual coalface workers type of thing there. And again, the priority of that area for us has actually been Aboriginal health workers to make sure that they've got information available to help what they're making decisions. We do, though, actually provide a whole range of things which would be applicable to other people working in the primary healthcare setting. For example, we have various resources available there. And the type of resources we have, we actually talk about in two different ways. One are health promotion resources, which the practitioner will use in actually dealing with an Aboriginal client. The other one are what we call practice resources. And these are the type of ones which practitioners themselves will actually access to actually improve what they're doing. We call those practice resources, reflecting they are for practitioners. We've got a whole database of these there. So people actually have got the capacity to search through the database for the information we want. And each of those actually is still needs further development. The health promotion resources database is fairly well developed. So therefore, if a person's working in the health promotion area, for example, and they have the task of, say, developing resources, say, addressing smoking amongst the Aboriginal people, they can look at our database there and see the range of things that have been done around the country. You can see the potential value of that there, because it really means that people don't have to reinvent the wheel. They can start off without having to go back to square one. Okay, they've got some things to look at there. I mean, reinventing the wheel is a really good old statement there, because the trouble is, in health, we tend to still do that when we're developing resources like health promotion resources. We'll think, oh, we'll have to develop it ourselves. Whereas really the core of that resource, it can be standard one across the country, but be adapted for local circumstances there. So say, for example, one was developed here in Perth, WA. It may need to be developed for people, say, in North Queensland, to actually tailor a little bit for the nature of Aboriginal populations up there, or the Torres Strait Islander, tailored separately there to make sure it actually is applicable for that particular population. But broadly, the science underlying it all is fairly standard across the country, and it really means just adaptation to make it relevant in regional areas. One of the things that you'll find for people working in remote areas, many of them may be new to the topic and new to the area itself there. So what we try to do, for example, is provide a range of information that will help people hit the ground running virtually. Okay, so for example, we do reviews on the topic such as volatile substance misuse. So imagine, in fact, if you were a person appointed, say, to work in Alice Springs there, and you never knew much about either Alice Springs or volatile substance misuse, then our review would be an incredibly good point to start with, because just by reading that alone, you could actually get some sense of actually what the topic's all about and why it's important, why you've been appointed to the job there. Now, after you've done that, you can then tap into our literature base there, because we've got by far the best literature base of Aboriginal health literature in the world, as you would expect, okay, and it's an enormous resource there. So what we will tend to do is actually both group publications according to different types. So say, for example, your task was to look, in fact, at addressing volatile substance misuse, the social impacts of that there. Within our literature, we've got that subdivided in such a way you can actually look at the literature related to the social impacts of volatile substance misuse amongst your population. Now, if you were particularly keen, you would probably want to go a little bit further, and you may want to look at our full bibliography related to that topic though. So we've got a separate downloadable bibliography of volatile substance misuse out of our total bibliography of about 17,000 items. And so therefore the person who was really keen, they could actually do that. And within 2 or 3 days, they're actually really up to speed in a way, rather than the normal way of doing it, which is an osmosis type of process, which might take months. Within our volatile substance misuse area, for example, we'll actually list in organisations that you may want to call on. So there may be bodies that actually help give you professional advice about what you're doing there. Another thing we do within that area is we're going to let invite you to join our yarning place. And our yarning place is an electronic network to allow people working in the areas, in this case more broadly substance use, not just volatile substance use, to actually share their knowledge and experience around the country. So for example, that yarning place then will provide not only a list of people around the country, their telephone numbers, emails, you can track people down, talk to them by email, okay, or by phone, because phone numbers are provided there too. And again, the type of service we provide there is an old-fashioned listserv, which is really just a distribution list, so people can actually ask questions of others or share information amongst them. There's also a discussion board, bulletin board, which we call a yarning board, where they can actually go on and actually have a bit of a dialogue and actually debate issues about why a particular program has worked or not worked. So they've actually got access to that type of information. And picking it one step further there, if in fact I've been asked, if you've been asked in your job at Alice Springs there to develop a particular program looking at volatile substance misuse, you can actually look at our database of programs and projects and then see whether one of those is relevant. So again, you don't have to reinvent the wheel. You can go and look at the information that's available on our project database and say, gee, that's a good program. Why don't I try to implement that in Alice Springs? and of course you'd adapt it to local circumstances in conjunction with other people that have actually worked in that area for some time. One thing I should emphasise to you, it's an entirely free resource, so everything on the internet is actually available to you free for your use. Downloadable PDFs, information about other services, this type of thing there. And again, that's the type of thing that we try to bring to you. Now we work very, very hard in trying to be thorough and complete about that there, but of course we can't be totally complete. So actually we also ask your help, okay, in bringing attention to us any items which actually we haven't identified. You may come across a program in your area or a project that you think is really worthwhile sharing with others. You can either do it through the yarning place, which will get into particular areas, or you can preferably give it to us and we'll put it in our database. Because the trouble is that we may do all the collections we can do, and we're very thorough on that. I'm very proud of the way we do this there, but we're still going to miss some things, particularly local things that may have been a document or a project that's been developed, say in Alice Springs, but again, which we haven't actually managed to track down. So it's really important for you to spread the message amongst yourselves there, to get on the website and use it there and actually see how you can actually guide us to make it even better. Because again, we're really welcoming feedback all the time from users to make sure we can actually improve it for you. Because it's there for you to help your decision making to actually improve the lot of Aboriginal people across the country.
Thanks to Neil Thompson and the team at the HealthInfoNet for taking the time to chat with us. Finally, we look at a program that supports patients in making the lifestyle changes needed to prevent further problems after a cardiac event. We went to the Derbal Yerrigan Health Service based in Perth to talk about their cardiac rehabilitation program.
We started, they had a symposium in 2008 where they got a lot of the elders together here, because elders are essentially important in the community itself, and then the community and the elders. It was run by the Heart Foundation of West Australia, by a lady called Lynn Dimer, and the community decided that they needed a cardiac rehab program, because basically we know that Aboriginals don't like going to hospitals for cardiac rehab.
So the heart health program was initiated by a lady called Lynn Dimer, who's the coordinator of Aboriginal Health here at the Heart Foundation, and it came from, there was a symposium I think in 2007 which there was a lot of community engagement, and there was reports and statistics at that time saying that Aboriginal people weren't accessing cardiac rehabilitation.
They alerted us from Royal Perth Hospital that the patients that had heart problems and were having heart attacks and then getting back to health, that they weren't attending the rehabilitation program. So we looked at bringing the rehabilitation program to the community.
And so we wanted something that was more appropriate for the Aboriginal community, and this program kind of came about from that. We got our funding from the Office of Aboriginal and Torres Strait Islander Health, and from there we also modelled it on the Witropiran program, which came out of Queensland.
And then midway through 2008 we decided we'd set the program up, so I used to come down and visit here about once a week, trying to build out bridges and stuff like that, and eventually we thought, well, we've got to have a start date, so we started in 2009. We started in March 2009 and we've been going ever since then, so for the last 2.5 years. And
we're now at the stage where Derbal Yerrigan has taken full ownership of the program, and that happened in 2010. So the Heart Foundation has very much stepped back, and we're at the stage now where we still support the program. I attend every week, and also we have health promotion resources that we offer and provide. That's the ultimate goal, to initiate something and then step back and have someone else take ownership over it in terms of sustainability and things like that. That's what you're aiming for.
We have a variety of people. When we first started the program, it was meant to be cardiac rehab, so we just thought we'd just do heart disease. But then what happened was we started off at the beginning, and then all of a sudden someone was riding a bike and looking out the window and would wave to someone and then jump off the bike and go out the room, and I think, oh, we just lost someone. It's disastrous. But then they go and bring someone else in the program. So then some of the elders were out there, would go out and talk to their friends in the foyer and say, look, come on, you need to do some exercise and look after your health too. So then they bring them in. So it turned from a hospital referral program to a self-referral, and now we get a combination of the two. We looked originally at heart disease, but then when I started the program, about 70% of the patients or clients were diabetic. About 5% are renal patients. So we then start looking at, well, we need to introduce a sort of diabetic component to the course. So we try and have a little, maybe 20 minutes, half an hour each session on diabetes.
In 2008, South Metropolitan put in a program, The Journey of Living with Diabetes. It was adapted from the mainstream to Aboriginal for Aboriginal people, for the Noongars, and it's got a 6 session, like based on the 6 seasons of the year. It was launched in 2007 at Derbal Yerrigan here, and the health works from the South Metro is going out to promote the program to the community. The first time I came in here to do the Journey of Living with Diabetes, I had about 5 people, and the second time I came it was 10 people. At the same time, Ted was doing the health program, and he was sort of more or less, he heard that I was doing the program, the Journey of Living with Diabetes, so he said, well, you know, we put the 2 programs together. And I found out that it does work better, because when I first started coming in, I had about 9, 10, that's through the day, and then some people were coming in at different times after I did my session. But yeah, so now we've get up to about 30, 35 people coming through, and it's a rolling program. I talk about what's diabetes, how to measure their glucose, sugar levels. We talk about their diet, physical activity, and sick days, and the hypos and hypers of diabetes, how to manage it. And yeah, so I've been doing it now. This is my 3rd round, so it's usually a 10-week session, but this is my 3rd time round.
Well, we do the general assessments, the vital signs when they first come in, and check them, and then you know that creates discussion about how they're feeling, how they've been feeling for the previous week, or how they've been, yeah, and they'll tell us, you know, oh, I haven't been feeling well, you know, different things. My blood pressure's been up, or my blood sugar's been up, and so when we've done the vital signs, we'll find that out, and then if there's any sort of really abnormal results, well then Ted will look over that, and then it's easier for us to get them in to see the doctor.
We want a bit of ownership from the patient, from the client, so we get the clients to test their own sugars when they're sitting with us. If your client can't do their sugar in front of you, then they're not going to be able to do it at home. And that's about giving the client knowledge, and therefore they have choice. A lot of Aboriginals in the past have had modulars like myself, sort of telling them how to live their lives, but our program is about giving them choice and empowering them to then decide for themselves how they want to manage their health.
After their heart rate and their blood pressure is being taken on every day, we just make sure that they're feeling all right, and we try and encourage them to jump on the bike, just to pedal at a comfortable talking pace. Really, it's not to get the heart rate up or to pedal at a certain distance. It's just entirely up to the individual, and if they're having any symptoms or anything like that.
Yeah, Ted will say, oh no, you can't be sitting down doing nothing, so you need to get up and have a ride.
What happens is you try to encourage people to go on the bikes and trying to get them to do as much as they can manage, you know, and also based on their clinical restrictions as well. Then we add up the kilometres each week, and we've then get a weekly total, and then we add the weekly total to everybody, because it was like a group thing. How far could the group ride? Initially we started off in Perth, and then we thought we'll aim for Broome. So we got way past Broome at the beginning of the year, and now we're at 200 k's out of Alice Springs, which is just it's a monumental distance when you really think about it. So, and part of that was to motivate people, so we had a little newsletter where we wrote about how people were riding a bike, and then, you know, some of the guys can only ride a K. So what happened was they might have caught a puncture and had to get off the bike, and then someone else would get on the bike and ride 10 Ks, and then he'd get hit by a kangaroo that was hopping across the road. So it was make up funny stories, and it was a bit of a newsletter, and everybody had a good time having a chuckle to see what had happened to different people in the group when they were on the ride. And then we talk about where they went camping at, and then we get photos off the internet about different places that were along our trip. Just to make it all fun. The whole thing was just to try and make it fun and enjoyable.
Okay everyone, we're off for a walk in 5 minutes. If you need to go to the toilet, you better go now, otherwise you've got to do it on the road.
Start out the back door and you come in the front. Out the back door. I'll try.
After everyone's floated in, we try and go for a walk. Everyone's got different abilities, so some people just walk around the block, other people do a big walk. There's a big park around the corner. When we come back, we do a group exercise session, so we mainly just use free weights and our body weight exercises in a group setting. So they do get tailored individual exercises as well that we try and encourage to do at home. And then everyone has different sort of, someone might have a shoulder problem or a knee problem, so you kind of have to just keep an eye out on who's got what while you're actually going in the group setting, but then they know what they should and shouldn't do anyway. We've kind of all had a bit of a one-on-one chat with me just to make sure that they're doing the right thing inside and outside of here. But I suppose at the end of the day, the main message is to try and do stuff without us. So we just say a lot of things. When we first started, we just got like a Coke bottle or a Gatorade bottle and just filled it with sand and gave them to take home as their dumbbells. They have a bit of a handout with pictures of different exercises that they can and can't do, and they've crossed out the ones that they can't do if they've got a really bad injury or they should be doing, and encourage them to walk as much as they can around the block.
Some of the guys haven't seen each other for 30, 40 years. You know, they're playing footy together and then they catch up here. And that motivates them to go walking again. When they're walking, they're telling me about when they used to play footy and about their grandkids. And again, I don't have to force them to go for a walk because they're quite happy to go for a walk with their mate that they used to play footy with, you know. It's just fantastic.
A lot of them really enjoy the social aspect of it, so that's why we do more of a group weight setting. So they're kind of in the circle, in that kind of atmosphere, and they chat to their friends, and we've got music playing, and it's very chilled out and relaxed, and sometimes it's hard to get them onto the next exercise and things, but it's all part of the program, and I think that's why they enjoy it too. If I was to grab an individual and sit down with them and make them do all this weights, just me and them, I don't think we'll get much out of that. And at the same time, there's so many of them that come now that I can't kind of spread myself too far. So yeah, it's really good at the end of the day. Even the walking and the chit chat around on our big walks is, yeah, it's all part of it. I think that makes me feel a little bit better as well. I kind of feel a bit more relaxed in this atmosphere, so yeah.
It's very friendly because it's run totally different from what it's run in the hospital. They do run a rehab program in the hospital, but this program itself is totally different, where people feel more comfortable because it's a more relaxed atmosphere, and it's not as, well, when you run in the hospital it's a bit totally different. We're here, most of us know each other. I mean, most of us are all related anyway along the line, so we do know each other pretty well. So, and the good thing about it, you get the men and the women come, which is good because, you know, women do tend to look after their health where men don't. They tend to neglect it. But this program has brought a lot of them out where they do come and they do learn all about, you know, what they can do for themselves and that. So, but as I said, it's an excellent program and it's been running for nearly 3 years now. So, yes, it's a good program if they can run it in other communities, which people will benefit through it.
Everyone comes here to see the doctors, and it's a meeting place for everyone, and people from different areas come to meet here, and they haven't seen people for years, so then they come back every week and have a good old yarn with people, like different families they haven't seen for a while, or they just come back just for the friendship, you know, because some people are by themselves, live at home, and they've got no one else home there, so it's a day out for them, and it's a day to get out and enjoy themselves. And it's not only that, like I do the diabetes, Ted do the heart, they do the bit of physical activity, and then we've got 2 guys, which we've got one today, play the guitar, and they sit back until the afternoon after they had tea, and then, yeah, it's a day out for the people in the community who comes in. And the majority of them find their own transport in, so it's not as if, you know, they can't get in, or people do get picked up and brought in, but it's not that many. But most of them just come in just for the day out and just for the atmosphere at Derbal. So it's a really good place for them to meet.
It's the Aboriginal way of how we get together and how we do, you know, we talk about things. It's the yarning, you know, it's just casual, and a lot of our patients, they do have a lot of trust in us as practitioners, in the community. So we're lucky to have that, and they feel comfortable to talk to us about their medical conditions. They're getting information and they're getting, the education, and it's like education, but it's not, it's given in a simple manner, like easy to follow, and people are able to actively participate in that conversation.
He teaches us all about the heart and everything that we need to know, the education of it, and I think we've learned so much from him. And one thing, myself personally, I've learned a lot, because it teaches us the responsibility about our health and what we can do about it to change it. Even though the majority of us, a lot of us got heart problems, at least we know, what we can do about it to make things a lot better in our own health. And I've always been a great believer of anything of the education of it, and that applies to the diabetes as well, which they run in conjunction with both these programs. I mean, I myself had open heart surgery 7 years ago, so I do try and, make things better for myself, and I never miss coming to this program every Thursday, and sometimes I don't always feel like it, but I do make the effort to come in and to come and learn what we do.
Other things like if you're low on your potassium or your magnesium, that can sometimes cause it. So that's why when you go see your local doctor, I use a lot of imagery and stories. If I want to tell you, the hospital tells you you've got a stent in D1, D1 doesn't necessarily mean a lot to you, but if I tell you your right coronary artery is Wanneroo Road and the Mitchell Freeway is the LAD and the circumflex is West Coast Highway, and you've got a stent coming down Hutton Street, people actually understand that where the stent is now. And if I'm describing angina for some people, it doesn't really mean anything, but if I describe it as it's a congestion at peak hour traffic driving home along the Mitchell Freeway, and a heart attack is when all 4 lanes are blocked because the trucks had a rollover, and people actually understand the difference between the two. And then the stories I tell about is, we get the group to tell stories about what their heart attack like, or where their heart attack was, and where their angina was, whether it was in the chest, the back, the shoulder, or the diabetic patient who didn't get any pain at all. Then the community and the group shares their experiences, and that's a lot more powerful than me sitting up there with a PowerPoint presentation. With Aboriginal programs, it's very important to use elders. An elder can get 3 or 4 people in the foyer to come in when I can only get 1. If an elder tells you to go to this health program, then you listen to the elder and go to the health program. As a health professional in the hospital, I have lots of referrals, but I still can't get them here, but the elders get them here. And I'm always here. So a lot of the programs, one of the big, if you're going to open anything, never use the word trial. Hospital programs love using the word trial, and we had it at the beginning of our program because it was a pilot program. That means Aboriginals are sick of non-Aboriginals coming into an Aboriginal setting and setting up a pilot or a trial, and then they walk away after 8 weeks. So when I started the program, it was, and how long are you here for? And I go, we're here forever. No, how long are you here for? So once the community, it was incredible. After about 6 months, there was this huge jump in our attendance because the community worked out that maybe they're not actually going. They're here for a while. And now the clients, I bump into some people walking here from the car park or in Perth City, and they go, oh yeah, you're still going? Yeah, we're still going. And they go, oh, you're joking. Like 2.5 years for a program, I get 2 or 3 phone calls each Thursday with little texts saying, I'm out bush, I've got stuff on, because the group is taking ownership for it. The group is taking ownership that the reason I'm not here is because, whereas most programs don't get Aboriginal people ringing in to say, I'm not coming this week. So it's the group that's, and often I don't see people for a while, but when they run into troubles in the hospital setting or in the community or they've gone off there, one of the guys has come back because he started smoking again. You know, has been smoking free for a couple of years, and now he's back smoking, so he's decided to come back to the program just to try and help him. A few others have, you know, maybe put a bit of weight back on, so they want to get back into the program again. And then they'll be with us for, you know, maybe 2 or 3 months, and then they'll drift off, and then maybe we'll see them once a month, and then they'll come back to the program again. One of the guys wouldn't come for a walk. He wouldn't come for a walk. I used to ask him every week. He'd go for a ride, but wouldn't come for a walk. I asked him for about 6 or 7 weeks, and then I said, look, if I bring a pair of my running shoes from home, will you come for a walk? He said, yes. So then I got him a pair of running shoes, and he's just kept on walking ever since. And he's lost about 10 centimetres off his waist. For him was that he couldn't afford walking shoes, couldn't afford sneakers to go out, but we get them donated now. So for him to have that freedom to go for a walk and exercise when he wants to now, that's huge. So some of the other clients come here for other reasons. Some were socially isolated or had emotional issues where they weren't used to going with other people. So we've created that social outlet where they can now go out of home and then be in close contact with males, whereas before they weren't. They then feel comfortable in this environment, so then they've stretched themselves to going into shopping centres. So again, that creates a whole lot of freedom that they wouldn't have had before.
Lay your legs up.
Yeah. Yeah. So if you've got low blood pressure, what does it mean? It means you're not getting enough blood to your head.
You got no blood in you.
So you need to get blood to your head. So you need to walk around when you've got low blood pressure. No. So you put your feet up high. The blood goes from your feet down to the important organs, which are your heart and your head.
In dialysis, they almost stick them upside down. Like
I work in the hospital at Royal Perth. I'm only seconded down here 3 days a fortnight. And we get referrals from all the different hospitals, all the major teaching hospitals. And then any of the country patients that are in Perth who may, for one reason or another, not want to go home, they are invited into the program as well. So they may come to the program once every 6 months or once every 3 months or when they're down for a funeral or whatever. They had the freedom, and a lot of our clients only come when they want to come. Some come every week. We have like a core group of about 10 that come each week, and then the rest are a bit more transient. There's a few guys here that I haven't seen for about 6 months. And I had a few ladies at the beginning of the year, they said, look, last year I wasn't here because I was looking after my grannies. Now it's my year to look after my health, so I'm here. A few of our renal patients are down here because they need to lose some weight so they can get on the transplant list. So different people, some of the guys don't have heart disease, don't have diabetes, but they want to lose weight. And so they've brought themselves to the program for weight loss, to have that support of doing exercise in a supervised environment with exercise physiologists.
You know, we're from the Noongar country. However, there's a lot of our other, like people that come from other parts of the country, like the Wangai people, the Yamaji, so, you know, from all over WA. And they'll use, if they use Royal Perth Hospital, well, we will get the referral, and then Ted will check them out because, you know, he works on the cardio ward at Royal Perth. And then we tell them about our program here, and while they're here in Perth, well, they can come to the program, and then when they go back home, we'll let them know that they have been attending here, and if there's any programs around where they are, we'll refer them on or let someone know in the area that they're returning home.
We've had about 120 people come through the program this year. I'm not quite sure the exact number over the 2.5 years, but people keep coming back. And if you look at how far we've rode, that's a huge thing. And there's different stories. Nearly everybody in the room has had some sort of health issue where we've been able to make some sort of impact on their life or their family, and if you're referring, if clients or family members are referring other family members in here, they're obviously doing something the right way, which that's word of mouth. The reason you and I go to watch a movie or to the theatre is because, not because we see a poster on the wall, but because someone recommends it. That's more powerful, and that's what we need to look at with our communities, is create that conversation in the community that we can make a difference, that we can maintain diabetes and high blood pressure and heart disease. We don't have to necessarily look for the cure, but we need to give our clients a choice on how to maintain it without telling them how to live their lives. They don't need that anymore, they just need to have the choice.
Well, that's all we have time for. Thanks again to everyone involved in today's program. We'll be back on the 1st of November for our final program of 2011, focusing on poisoning. Thanks for joining us.